Again, welcome to EPI Research Method. This lectures will cover chapter 3 of our course textbook. That's an overview of epidemiologic study designs. So our main objective again is to go through different types of study designs used in epidemiology. Also, we will go through the element of study designs, which represent HUIT. H stands for hypothesis, whether tested or not. U stands for unit of observation. It can be either individual or grouping. And also intervention and timing of exposure and outcome measures. Also, we're going to link the study designs to appropriate research questions. Again, our previous lectures, which is chapter 2, we discussed about 4 different types of research goals. So we are going to link it with the different types of study designs. And normally a research goal can determine the type of research study designs we have to use. So also we're going to distinguish between study designs in terms of how HUIT elements are treated. And lastly, we determine the appropriate use of each study design. And we shall also give some examples. So here we say the review of common designs used in epidemiologic research is again our main objective today. And also research questions should always influence the choice of design. Always again, research questions should determine the type of study design we choose. Also, choices may also be limited based on the resources that are available for us. Always we need to balance between the methods and also the practicality. So sometimes again, the research questions must be adjusted accordingly. So we start with the HUIT elements, which is again, H stands for, as we said, hypothesis. It's either tested or not. U will be the unit of analysis or observation, and it can be individual or group. I will stand for the intervention or treatment, and we need to evaluate it or not. There are some studies design method which doesn't allow us, or we don't need to evaluate intervention or treatment, or even test hypothesis. Some study design may help us to generate hypothesis, which is normally the descriptive study design. Again, we may go through that in a few minutes. So again, a research hypothesis is the statement of the association, the causal relationship, or intervention effect we wish to test in our study of health phenomena. So an example would be the risk of lung cancer increases when the number of cigarettes smoked per day also increase. We can tell this can be an hypothesis. So is there any relationship between the number of cigarettes we smoke and the chance of getting a lung cancer? In terms of a unit of analysis, again, it can be 2 options, either individual or group. We have epidemiology study design that again use group as a unit of observation, which again go through an example. So the unit of the observation, as we said, can be either single entity from which we collect our data, or again, it can be a group. So for a per se unit, we collect and also analyze individual data points. Example can be body mass index, or experimental or control assignment. But for a group unit, we need to consider the group as a single entity and collect and analyze the average data as per capital fat consumption or the mean BMI. So for example, for individual, we can again find individual body mass index or BMI. Now, if we are dealing with group, we can take all the group data for their BMI, then we use the mean or the average of it. Then also the intervention, either evaluated or not. So in epidemiology research, an intervention is an effort that we implement to prevent or improve the natural history of a disease or health problem. So the effort can take the form of an experimental drug, or it can be a surgical procedure, any type of treatment or intervention, or it can be an health promotion campaign. And also it can be a law to modify behaviors, or it can be a screening program. And the timing, again, temporal ordering of the time of measuring the exposure and the outcome. Always outcome can be either a disease or a death. So again, this element of the study design concerns itself with the timing of the measurement of the exposure thought to be treated to the disease or the outcome related to the timing of the outcome measurements. So again, we shall start with the different type of study design. The first one we're going to discuss will be the case report and also the case series. So normally a case report is the most basic descriptive design. Again, the most basic descriptive design, study design. And this is usually conducted in a clinical setting. And it normally involves the description of symptoms and other potential relevant characteristics for a single individual or a patient. So case reports normally are used together and report information. Again, case reports are normally used to gather information or to report. And this information again, later can be generated to hypothesis and it will need to be tested. With case series, it's the same as case reports, but case series again is a collection of case reports describing the characteristics of a small number of individuals with similar symptoms. So a case series will be when we have 2 or more case reports. So let's go through the characteristics of, again, a case report and a case series. The 4-element hypothesis, tested or not, with case report and case series, we normally don't test hypotheses. Actually, case reports and case series, we can normally generate hypothesis, but not testing. So that's why it's a descriptive. Again, chapter 1, we discuss about 2 types of epidemiology, descriptive and analytics. Descriptive epidemiology, we don't test anything. The exposure and the outcome are not tested. We try to understand the phenomena of the health phenomena, the issue. So descriptive may help us to generate the hypothesis. Then in analytic epidemiology, this is where we can find the difference, test the hypothesis to find the relationship or differences between exposure and outcome. So again, with the case report H, which is hypothesis, no hypothesis tested, the unit of analysis is individual. There is no intervention. There is no intervention. There will be intervention if we can test the hypothesis and find, first of all, before we have any treatment option, we have to know the relationship between the variables, in this case, the exposure and outcome, or the risk factors and the disease. So if the risk factors causes the disease, then we may come up with a program of intervention or treatment. So since there's no hypothesis testing, also there's no intervention. Also with the time, it will be a temporal order is not relevant because there's not hypothesis exposure. We don't know the hypothesis. We didn't test anything, so we cannot find any timing between the exposure and outcome. It's irrelevant. The defining characteristics is normally used for small number of subjects. It can be only one or few. If it's one, then it's a case report. If it's more than one, we say it's case series. The strength is it examines a new disease. Also, it's very easy and generate hypotheses. The weakness is that there's no control group for comparison. Can't address any specific question. At first, we cannot test the hypothesis, so there's nothing, and also no intervention. Now, let's see an example. Here we have a HIV/AIDS research, and we say the earliest information about what we know now as AIDS/HIV was learned from case studies and also case series of patients in 1981. There was a common characteristics of these patients that they are male, they are very young, based on their age, supposed to be healthy, and one of the characteristics also they are homosexual. They stimulated hypothesis that the mysterious disease was somehow transmitted through homosexual contact. Again, this was a study that was done in 1981 in San Francisco. Now let's move to the next study design, which is called the ecological studies. So with ecological studies, also is the same as case report or case series. It's a descriptive. Ecological studies is a descriptive studies with groups as a unit of observation. So the unit of analysis is grouping. Again, here we wrote individual, it's supposed to be group. Also the same thing, since it's a descriptive, there's no intervention tested. Also the exposure and outcome measures at the same time. So groups can be, example of a groups can be a household, neighborhoods, schools, hospitals, based on countries, even religion, etc. So to be, again, the unit of analysis is grouping for ecological studies. So the defining characteristics is that the group as the unit of analysis. So ecological study can, to a limited extent, measure the temporal order of exposure and outcome. But again, the lack of precision in average measures make it difficult to conclude with relative certainty that the exposure preceded the outcome. The strength with ecological studies, again, can be used data already collected. It can use the data that's already collected, and also can consider a social or group influences. And the weaknesses, the imprecise measure of exposure and outcome. And that is the concept of ecological fallacy. And we shall again explain what is ecological fallacy. Ecological fallacy normally is mistaken interpretation of study results of group level data to the individual level. Again, the group level data to individual. And so, for example, we may say, okay, we have a specific household or a country do something happen in a specific group, let's say a country or a school, and we apply the result to everybody in the school or the country. And actually, when we look at it individually, not everybody in the school or the country have that problem or have that issue. And there's an example given here. Fallacy was first noted in the work of Emily Durkheim This was a 19th century social thinker. And there was a found that most Protestant European countries had a higher suicide rated comparing to Catholic countries. But there was a mistake, because we cannot assume that individuals who commit suicide are Protestants and not Catholic. Maybe majority are Protestants or majority are Catholic, but not all Protestants or all Catholic commit suicide. So an example of ecological studies of HIV/AIDS research. Again, here we say ecological study of ethnicity and HIV prevalence found that American nations with higher proportion of immigrants from Africa, Asia, and Europe also had higher prevalence of HIV. Again, the goal here is that we want to apprise specific people from a specific geographical area that majority of them have HIV. It can be true, but again, not all of them. So next is the cross-sectional studies. Cross-sectional study, again, the unit of analysis is individual. It's individual. These studies are also called prevalence studies. It's also called prevalence studies. The prevalence is more or less like a proportion of something. So let's say example, data was collected about health phenomena. The population in that geographical area is 1,000. And we found out that 250 people have the problem. To find the prevalence, then it will be 250 divided by 1,000. So again, these studies are also called prevalence studies because, again, it allowed the calculation of the prevalence of health phenomena in the study population. And the hypothesis tested here, yes, hypothesis tested. Intervention, no. The reason why there's no intervention, in cross-sectional studies, data is collected at a point in time. So the timing, the exposure and outcome are measured at the same time. So in this case, we cannot 100% be certain that the exposure causes the outcome because there's no interval of time. It's a point of time. So that the defining characteristics of cross-sectional studies is that the exposure again and the outcome are measured at the same point in time. So this design is equipped to identify factors that are associated with the health phenomena, but causality cannot be established without the proper temporal order of exposure first and the outcome later. And the advantage is that, again, it can measure the prevalence, and the time and the cost efficient also. Disadvantage cannot establish, again, as we said, the causality because cannot prove exposure comes before outcome in time. And also inefficient for real outcomes. So example given here, there was a study of injection drugs users in Madrid, Spain. This was 1996. Now the risk factors for self-reported HIV seropositivity included passing and taking use syringes, and also inconsistent condom use with different types of partners, and variety of types of drugs use and history of incarceration. This can only assume, again, risk factors preceded the infection. So next will be the case control studies. Again, with case control study also, the hypothesis is tested. The unit of analysis in case control studies also is individual. Also, intervention, there's no intervention tested. Timing, the outcome is measured before the exposure in the study time. So again, case control studies are especially valuable for studies that have a rare or emerging disease or disorders. Diseases that are not common, because here we may have the case and the control. So we can find the effect. We can compare the case and control to see the effect of the risk factors or the exposures. So case and controls are identified from either in the clinical or general population sources. So clinical sources can be in the hospital or clinic, medical practice, etc. Also, the defining characteristics is that we may have two separate groups identified for data collection. People with the outcome are called the cases, those who have the disease, and people without the outcome, they are called the controls. The potential weakness of case control studies, again, is an inability to calculate the incidence or prevalence of the outcome. Again, as we said earlier, cross-sectional studies was very good to calculate the prevalence. And also later on, we will see the cohort studies. The cohort studies is good for incidence, to calculate incidence. So normally we say cohort studies and incidence studies also. So we have an example here, the study of a Belgian man who had lived in Africa. This study was 1988. 33 men with HIV and 119 men without HIV. And they were, so this would be the case control. The 33 men with HIV will be the case, and 119 men without the HIV will be the control. They don't have the disease. So yeah, they found out that those with the HIV positive men were more likely than HIV negative men to have had, again, one, sexual contact with local women in Africa. And here they found the odds ratio to be 14.7 based on the data collected between the case and the control. Also, they found out that the sexual contact with prostitutes also, the odds ratio is 10.8. And also medically prescribed injection by unqualified medical staff, they find the odds ratio also between the case and control is 13.5. So we can see the difference in a very good example here. This case, we have the case, 33 men with HIV, the control, 190 men without HIV. Now, taking the data and their behavior, we came up with this odds ratio. Now, the next one is the cohort studies. Again, cohort studies also, as we said, called the incidence studies, because they are designed to measure the exposure and also the outcome in the context of time. Incidence studies is trying to find the percentage of new cases or the proportion of new cases. So in this design, again, individual subjects are followed over a time period to measure the exposure when it happens in a real time or historically. Then measure the outcome at a point in time after the exposure. So cohort study means there's the timing, exposure is measured before, prospective, or after, which is called the retrospective. Retrospective means the subject have the case. Now we have to look back in time. Let's say a year, 2 years from now, what are the behavior of the person before it has the case. Prospective, we look at the future, what the subject is doing and what are the effects of the exposure, what will happen. So With cohort studies, again, that's why it's called cohort. We have to have a time interval. We can have a cohort studies trying to find out the relationship between cigarette smoking and lung cancer. This study can take 10 years, 15 years to see the effect. This would be called the prospective cohort studies. So while, again, the case control studies are limited to odds ratio for measuring association between the exposure and outcome because there's no time interval. With cohort studies, it allowed the use of risk differences, risk ratio, odds ratio for evaluating association. So the concept of risk is meaningful because the outcome or disorder is measured as incidence. So both risk and incidence are time dependent. So cohort study, again, we look at some period of time to see the effect. And as we said, cohort studies can be prospective, looking forward, retrospective, and also ambidextrous. So with prospective cohort design, we move forward in time. The subject first measure the exposure, then the outcome or disorder. So we look forward, exposure first, the outcome or disorder. Now, both the exposure and outcome are measured directly in a real time. But with retrospective cohort design, we move backward in study time. The outcome is already measured at first of the study, and then the exposure, which actually occurred before the start of the study, is determined by historical data, such as a medical record, employment history, or the subject memories of his behavior, etc. Then we also have the ambidextrous cohort designs. This will move both forward and backward in time. With this design, again, the exposure is measured twice, either historically and also in the real time during the study period. So the defining characteristics here is that the subjects are followed over time, either forward in real time or backward in historical time, or both of them. The advantage is that this can measure the incidence, very important. Also can demonstrate temporal order of exposure and outcome, since we have time period, and efficient for real exposures. The disadvantage is that it can be very expensive because this study takes time. We are using time, and also it's time intensive. Also potential for bias due to high attrition. So we may have, let's say, 20 people in the studies for 5 years. Some of them may not make it in the 5 years, or some may move from one state to another, or some may decide that they are no more interested in the studies. So higher attrition may have effect on the outcome of the results. So attrition again means the loss of subject over a time. Also inefficient for real outcomes and phenomena with long latency period. So example here, we have a cohort of homosexual men that were followed from 1982 to 1983. The goal here is to find the incidence of HIV infection, and they were able to find it to be 1.2% per month. So since, again, cohort studies, we are monitoring the subject within some period of time. Anytime they're exposed to something, every time we can measure what is the outcome based on the exposure, the risk factors. So that's why here the results said we have 1.2% per month of HIV infection. These homosexual men didn't have no HIV, but they were monitored from 82 to 83 to find out. This study was done in 1984. Now, the greater the number of partners and incidence of receptive anal intercourse, the higher the incidence of the infection. So we move to the next study design, which is called the community trial. Also with the community trial, the hypothesis is tested. Hypothesis is tested, Also, the unit of analysis is a group, is the whole community. That's why again the study is called community trial. Then intervention is tested, and also the exposure occurs and is measured before the outcome. So it's not like cohort studies where we can have retrospective. First of all, we have the outcome before we look at what was the risk factors that causes it. With community trial, always the exposure must occur first before the outcome. The defining characteristics, again, community trial can be experimental design with a group as a unit of analysis. The advantage is it can demonstrate causality. Since it's an experimental design, again, we can manipulate the risk factors, the intervention. Again, intervention is tested here. We can manipulate the treatment, intervention. So with this, we can measure the causality. So potential to minimize bias and confounding. Normally, experimental design, the bias and confounding is very minimal since, again, we are working in a real-time and lab setting. Disadvantage, of course, very expensive and also time intensive. And we can have ecologic fallacy because a community trial use unit of analysis as a group. Now, we also have the experimental studies. The experimental studies, the unit of analysis will be individual. So experimental studies like a community trial, but the unit of analysis is individual. So example given here is the analysis of HIV prevention trials using community. So in this case, we are using the communities and also treatment facilities as the unit of analysis. The study was done in 2001. They found a modest increase in condom use with causal partners. So this is a very little or no reduction in HIV and STI incidence, again, which means new cases, very little or no reduction in HIV, STI, new cases or incidence. So that would lead us to experimental or clinical trial. So again, experimental study designs, I will use the term, is the gold standard of designs. Because with experimental and clinical designs, especially if you use randomization, and the confounding and bias is very low. Most studies are observation, for example, case control, cross-sectional, they are all observational studies. Confounding and bias can be around. Experimental is the lab work. Experimental studies always reduce, again, the confounding variable or any bias. So experimental study design, again, I will use the term, is a gold standard of designs. The experimental studies, particularly randomized control and trials, are the most best or rigorous because of their use of random assignment to exposure groups, which also helps control classification bias and confounding. We're going to discuss about confounding variable concepts in the future lectures. Also, the idea of experimental design include a pre-test measurement of the outcome, which we can do, a pre-test measurement of the outcome, and also the random assignment of subjects into at least two groups, can be experimental and also control, and also careful monitoring of the delivery of the exposure. Then later, we do the post-test measurement of the outcome. So pre-test, exposure, then post-test design, follow the proper temporal order of exposure and outcome. So the advantage is, again, can demonstrate causality, potential to minimizing bias and confounding. And then same as community trial, the disadvantage very expensive. And since this will be based on timing, it's time intensive. Also limited external validity, which represent the intended target population. And sometimes it's subject to attrition bias. Again, since this is experiment, it's more or less like cohort, we may lose some of the subjects. Also, we may have what we call the hybrid designs. Hybrid designs are more common in epi research. And the most common one that is used always is using case control with cohort. So you have your cases, you have your control, then you monitor them for as long as you want. So that is the concept, using two or more methods together. So here we say again, epidemiologic studies also combine two or more study design into hybrid, combining parts or the whole of each design. The common hybrid design again is the nested case control studies or case control studies with cohort. So combining again element of two or more design. So example here is we have a group and individual level data that were analyzed to learn about HIV risk in African communities. This study was done in 2011. So the group level, they use permissive sexual norms and tolerance of polygamy. So this is again in group level. Then individually, the multiple, again, sex partners. So again, group and individual levels data that were analysis to test the hypothesis that society condition influence the high risk of sexual behavior in Africa. And at conclusion, again, here we have the designs and research goals. We are comparing with the, as we said earlier, research goal can determine the type of study design we should use. And in our previous lectures, which cover chapter 2, we discussed about 4 types of research goals, which is descriptive, association, causal, and evaluation. So here we can see if our research goal is descriptive or association, most likely we are going to choose case report, case series, ecological, or cross-sectional. Remember, association is not causal, as we learned that in statistics. Basically means we want to find there's a relationship between the two variables. Due to confounding and bias, there may be association, but there's no causal. Now, if I want to determine the cause of the exposure and outcome, then the best study design, you can see that there must be a time period. So we know case report, case series, ecological, cross-sectional. Normally, the temporal measurements is taken at the same time, at a point in time, not at some period of time. To know causal, we want to know, find out the outcome, why the exposure gave us the outcome. Input, what is the output for some period of time. So a case control, retrospective cohort, prospective cohort, and prospective cohort, they are all based on time period. Then also if we need evaluation, causal with evaluation, community trial, or randomized control trial also is another good method. Or even experimental design also is very good method. So that will be the conclusion of our chapter 3 course lectures. Again, in this chapter, we study about different types of epidemiologic study design. The most important thing we should know is that, again, the study design always associates with the research goals. In our previous lecture, we said there are 4 different research goals. And we can see in our last section, we've categorized it. Based on the research goal, we may know the type of study design we are going to use. And also, one thing we shouldn't forget is the availability of resources. When we are embarking on a research work, again, resources is very important. The resources are available, then that also can determine, and with the research goal, may determine the study design we use. So again, wish everybody the best, and thank you for your time.